Hi there, I'm Dr. Stephen Phelan. Welcome to my video channel. What I would like to do today is provide you with some more ideas and thoughts on treating full mouth cases. And I want to use a case that I'm currently working on as an example of the thought process behind sequencing a full mouth case. And in this particular case, the patient was referred to me by another dentist. It was very nice of this other dentist to send me the referral. And the patient basically has a posterior crossbite, and he's worn his teeth down to the point where there's a lot of attrition and erosion, but he's now an end-to-end anterior occlusal relationship. And his upper teeth are very short, so he has very little tooth display, and his goal for the case is to have more tooth display and longer teeth and more natural looking teeth. But the problem is he's developed an end-to-end occlusion and he has a posterior crossbite. So the number one treatment for him would probably be orthognathic surgery and orthodontics, followed by porcelain restorations, probably quite a few because he has a tremendous amount of attrition and erosion. But the patient's an investment banker and he doesn't really want to have that kind of treatment done. He feels it will negatively affect his ability to work. And you know, as an adult, I am not sure I would get orthognathic surgery either. I would definitely consider it, but you'd have to think long and hard whether or not you need to have that done to achieve your goals of your case. And so basically I did all the diagnostic records that I do on cases like this. You know, here's the actual diagnostic records on the articulator mounted, and the case is in fact end-to-end with a posterior crossbite. And we looked at the case in quite a bit of detail, and I actually sent a set of the diagnostic models to my ceramist, Mr. Harold Heindel, who's a master dental ceramist. And we talked about it because the patient really wanted to have this done restoratively without an orthodontic component. He was willing to do Invisalign, but he didn't want to do anything else. And realistically, Invisalign wouldn't do a lot for this case. So I spoke with Harold and we came up with a plan to open the vertical dimension and change the anterior relationship so we didn't have an end-to-end relationship anymore, and then lengthen the upper anterior teeth and keep everything pretty flat because he's very flat right now, and I don't want to completely change the way his jaw and muscles function together, but I need to get longer teeth. So we came up with a treatment plan, as I said, opening the vertical, and lengthening the upper anterior teeth, creating a better anterior relationship, but it will be quite a bit different from what he's used to. So when I'm having a case like that where I'm changing the anterior relationship significantly, I'm going to really test that out with the provisional restorations. If I'm opening the vertical a little bit, but keeping a relatively similar anterior relationship and similar angle of guidance and all of those things, I'm not as concerned about those kind of changes. I'm going to test it out, but I'm not going to wait an extended period of time to finish the case a lot of the time. But in a case like this, where we're really changing the anterior relationship that the patient is used to chewing with, I'm going to test this out for a more extended period of time, probably 3 months before we complete the case. And in this case, I brought the patient in last week. We prepared the upper teeth one day, did all the core buildups that were needed, took out any decay, prepared the upper teeth, and made provisionals. Now, those provisionals are not going to fit with the lower teeth at all. So I brought him in the next day, the next morning, and we prepared the lower teeth, did all the core buildups that were needed, made the lower provisionals. Now we have upper and lower teeth that fit together, as we envisioned in the Wax Up. And here's the Diagnostic Wax Up. And if you've been to my seminars, you know how we kind of take the Wax Up and create shells and make the provisionals to mimic the Wax Up. And there's a lot of ways to do that. And actually, I tried a new way for this case. So I'm going to share that with you in a future seminar. I'm actually putting together right now a new Occlusion Seminar, which will be 2 days and presented in Toronto and Montreal in April of this coming year in 2011. So look for the information on that. It's going to be, I think, the best seminar I've ever done. I have some really good ideas to improve the learning experience for the attendees. So basically, we do the Diagnostic Wax Up. I've got the provisionals now made from the Diagnostic Wax Up, and we're going to test this out for an extended period of time. And the good news is the patient felt very comfortable with the changes in his anterior occlusal relationship. Patients generally don't notice a big change if you open the vertical a couple of millimeters, but they do notice a change in the anterior occlusal relationship if you're changing that significantly. But he felt quite good. And the length, when I saw him the next day and he wasn't frozen on the second day, the length wasn't quite what we wanted, so I actually extended it with some flowable composite on the two central incisors, and now the length is more like what we want. And then I saw him a couple of days later. That's part of the sequence of treating these cases. I see them a few days after I've placed these provisionals. And his speech was really quite good. There's very little change in his speech. I didn't notice very much lisping at all. Initially, we did have a little lisping, and I had to adjust the palatal contacts of the upper anterior teeth a little bit to give him a little more freedom to speak. But after I did that, his lisping pretty much virtually went away. So these are all things that we want to think about when we're doing a complex full mouth case. And I'm going to prepare another video as time goes on and we work through the case and tell you about some of the other things I'm thinking about in treating a patient like this. But in the meantime, I just wanted to give you an insight into the initial stages of changing a patient's anterior occlusal relationship and lengthening their teeth and making a lot of changes for a patient with a full mouth rehabilitation. And basically, the one thing that I did do is I didn't do it in stages. When you're making that many changes, you have to do it all at once to test out the changes. So you either have to do some kind of bonded composite change on one of the arches, or you have to just prepare everything and do the provisionals. And my preference is, if I can, to prepare everything and do the provisionals, but it's not a bad way to do it with the bonded composites either. I have one case that I show that I'll probably show even more detailed in my next occlusion seminar, where we did bonded overlays as provisionals to open the vertical and change the occlusal relationship that way, and then did bonding on the front teeth. So there's lots of different things that you can do, and that's the exciting thing about dentistry right now. With bonded composite restorations, you can make a lot of changes and test them out without even preparing the teeth. So I hope you enjoyed this video. It's just some insight into how I treat some of my full mouth cases. And if you have any comments, feel free to email me or leave a comment on my YouTube channel. This is going to be on my blog in the new year, on my new website, and you'll be able to leave comments on the blog really easily. So thank you for joining us, and we'll talk to you soon.